Hey, this is Jeff Pipkin, and this is my physical assessment project for Nursing 305. Ms. Charlotte Kramer for the University of North Alabama. I'm going to be doing a physical assessment. This is my patient that I have contrived into coming here and helping me out. But we're going to get started with the lymphatic system. We're going to look at all the superficial nodes and just check those out. First ones we're going to do are the tracheal nodes. I'm just going to look here, palpate. Those are all non-tender, no pain there, Don. Any kind of pain or tenderness could be associated with inflammation or malignancy. The consistency, they are soft, they are not discrete, they are movable. They're not too firm to the touch. They feel like that they are consistent with what you would find in normal findings with that. They are smooth, symmetrical on both sides. We're going to check the brachial nodes. I'm just going to drop. Yeah, that's good right there. We'll go right under the axilla areas, and there they are. Both of those are symmetrical. They are easily palpable, but they are not swollen. No pain, no tenderness. Okay, they're consistent. Both of them are the same. If you'll lay down, Don, and we're going to do the inguinal nodes. I'll go through the boxers. Those are palpable as well. They're the same as the brachial and the tracheal nodes. They are symmetrical. There seems to be no tenderness, no pain. They're consistent in size. They are not too firm. The iliac nodes are right here, and they're the same. They seem to be in good shape, no issues. Symmetrical on both sides. They're both with the same consistency, no tenderness, no pain with those. Okay, you sit up there. Now if you'll lay on your stomach, we've got to get the popliteal nodes, which are behind the knee. These are both back here. There we go. These are both palpable. There are no swelling. Any tenderness, Don?
Nope.
No pain?
Nope.
Okay, so we don't have any inflammation. Don't have any malignancy, doesn't seem to be. Everything seems to have good vascularity. All the superficial nodes seem to be in good shape. You can move them all around, so they are mobile and symmetrical. All right. Well, that is the lymphatic system. If you want to sit back up, Don. Next, we're going to look at the eyes. And we don't have a Snellen chart in here, but a Snellen chart is what you would use to document for the vision, 20/20 vision, hopefully is what we would have. But we do not have a Snellen chart here. I'm going to do the confrontation test. Put your left hand over your left eye. And I'm going to do my right. Tell me when you see these, my fingers.
I see.
All right. Do the opposite side. When you see my fingers. Okay, so the peripheral vision is good with the confrontation test. I'm going to look at the eyes, inspect them. The retinas are blue. The pupils are round, look to be reactive to light. They are symmetrical. Both pupils are equal in size. The lacrimal glands above the eyelids seem to be in good shape. There's no tenderness, no pain there. Doesn't seem to be any swelling. The eyelashes are symmetrical. They're long. Texture is good on them. A little bit of gray in them, I think maybe. But the pupils, like I said, were round, reactive. The eyes move, symmetrical. They move in the same shape. No edema, no sagging. The eyelids are in good shape. I'm going to look at the conjunctiva. That is pink and moist. The sclera is white, no yellowing of the sclera, and it does have good vascularity of those as well. The eyebrows are thick and they are symmetrical. There are two of them, not one, so that is a good thing. But the eyes look to be good just from observation, no corneal abrasions, no redness, no yellowing of the eyes. The vessels look to be in good shape. The iris looks good. Now we're going to use our scope, ophthalmoscope, and we're just going to look at the eyes. All right, we'll look at this one first. The red reflex is there. The iris looks good. The pupil looks good. The cornea looks good. We're going to go and look at this one. This one is the same. The red reflex is there. The vessels look good, intact. I don't see any cotton wool patches, which could be indicative of nerve fiber damage. I did not see any hemorrhages, which could be indicative of hypertension or diabetes. Could be causing that. No retinopathy looks to be in place. Cover one of your eyes, and the other one is reacting to that because there's more light being added to that eye, so it naturally will dilate to try to pick up the eye. It's the same with the other, and that one is dilating as well. So the cover-uncover test was proper for his eyes. Everything looks to be good. We're going to assess the 6 cardinal fields of gaze. I'm going to hold your chin real quick. Just follow my eye. And for the final. Yeah. Now, 6 cardinal fields of gaze were positive. Everything was good. The eyes followed each other. They are symmetrical. Don't seem to have any issues with the pupils not reacting as they should. So the eye examination was good. The eyes are good. Now we are going to the ears. I'm going to look at the external ear first. These are pink. There's not any on this end, no scars. There doesn't seem to be any lesions on either one of the ears. They are properly aligned with the eyes, and they are symmetrical. Any pain in the external ear? If you had any pain in the external ear, that would be indicative of otitis externa. Any pain on either mastoid process, back here in the front, any pain or tenderness inside the ear, that would be indicative of otitis media. If we did have the pain at the back of the ear or the front of the ear, that could be indicative of that. They are symmetry. The shape is oblong, like it's supposed to be. They are 10 degrees from the head. The pronation is on that, and they are aligned with the eyes. We're going to look in the ears with the otoscope now. We're going to be looking at the cerumen fluid and the tympanic membrane. And if I'll get the otoscope instead of the ophthalmoscope, it usually works a lot better. All right, just going to take a look. Not to go in the ear, but just to look. There is cerumen fluid in there, and it is dark in color. Consistency is pretty thin. The tympanic membrane is observable, and it is gray. If you had red or bulging tympanic membrane, that would again be indicative of otitis media. So his is gray, which is normal. That's the normal color for the tympanic membrane. Going to look into this one as well. This one looks identical to the other one with the cerumen, the dark thin cerumen fluid. Tympanic membrane is gray, so everything looks good at that. The landmarks all seem to be there. The handle of malleus, the short process of malleus, they all seem to be there. So the external and internal ears look to be in very good shape and not having any problem. Now we're going to check and see how his hearing is, if he's having any conductive hearing loss. First I'm going to stand back and I'm going to whisper, and he can hear me. I'm whispering, I'm coming over here. Okay, and I can hear him, so my hearing seems to be okay as well. We're going to do the Weber test, and this is just for bone conductivity to the ears to make sure that the vibration is equal, symmetrical to both sides of the ear, or to both ears. Feel any vibration to either side?
A little bit.
A little bit. Is it equal?
Mm-hmm.
Not having any problems. All right, we're going, that's the Weber test, seemed to have bone conduction equal to both sides. Now we're going to do the Renee test, and we're going to check behind this ear. You hear that?
Mm-hmm.
You hear that?
Yeah.
Same, either ear, one ear greater than the other.
Same.
So that we had the same hearing in both ears with the tuning fork. So that lets you know that both ears are equally processing sound as they should. Now we're going to go to the chest and the lungs. I'm going to get Don to come over here and stand. I'm going to look for symmetry just with his normal posture. He looks fine there. Does not seem to have any lordosis or kyphosis, and does not appear to have any scoliosis from standing. But what we're going to do is lean him forward, and that way you can see the curvature of the spine if there is any. Can you just bend? Yeah, just bend straight over.
This one?
Yeah, it's like you're going to tie your shoe. The spine does seem to be in alignment. Does not seem to be any scoliosis going on. So, okay, you can stand. That does look good. I'm going to get you to lay down right here, Don.
Stomach.
On your back, I'm sorry. Yeah, on your back. And this is where we will inspect just the chest, just to see if we have any, make sure the symmetry is there. Patient's chest is symmetrical. No shoulder is pronated or stands out pronounced above the other shoulder. Everything is symmetrical, good muscle tone. Everything does seem to be in alignment. There are no lesions, no scars, no moles that would cause concern to think that there was something going on with that. Palpating, everything feels normal, no tenderness. No pain associated with this. Just stay right there. I'm going to. Now we're going to look for the substernal notch and the angle of Lewis, and that is theirs proper at the meeting of the two clavicles. And everything seems to be in proper alignment there. We're going to look at the trachea. If you can extend your neck a little bit. The trachea is midline. It is in straight alignment with the oropharyngeal area. It's not deviated to one side or the other. Tender, no pain, no tracheal pain or tenderness associated with that. Just on inspection, the respirations are good. Does not seem to be any stridor. Seems no pursed lips breathing. Seems to be just normal respiration rate of about 16 full respirations. You can see the chest rise and fall with respirations. So everything seems to be in good shape there. We're going to take a listen. Just going to listen to the lungs. Take a deep breath. Deep breath. Deep breath. Deep breath. We're going to change over to use the bell for the diaphragm area because it is more dense, and so this will pick up better sounds. We were seeing hearing hyperresonance and resonance over the full fields of the lungs. And this is a duller sound, which means that it is more dense tissue, which is normal. For that, you have your liver, have your spleen, have your diaphragm. So you would expect to hear more dull sounds from there. Okay, you can sit up. And we're going to look at the back now. The coastal angle upon inspection and palpitation was normal at the right here where the ribs do start retracting back. Deep breath. Deep breath. Deep breath. And deep breath. Okay. There were no adventitious breath sounds. Breaths were clear, bilaterally equally. So everything sounded good on the breath sounds. Didn't have any issues with crackling. Didn't have any issues with wheezing. So the breath sounds do seem to be good. We're going to check the vocal resonance. Okay, talk.
1, 2, 3, 4. 1, 2, 3, 4.
Now whisper.
1, 2, 3, 4.
Okay, that is audible. You could hear him talking and whispering in his lungs, which means they are clear and everything seems to be in good shape. The chest is not barrel chest, which would be indicative of COPD. If the backside was round, you can see how wide it is from shoulder to shoulder. The depth is smaller. If it was a barrel chest, which means that it comes around and the width and the depth are equal, that is indicative of COPD. So you would have to assess for that and start getting some pulmonary function tests done to see the significance of the COPD, see what was going on. I take it you don't smoke.
No.
That's a good thing. So by him not being a smoker, his no barrel chest, his breath sounds being clear, I think we can definitely rule out COPD. We will look at the fingers just to make sure there is absolutely no clubbing of the fingernails or the toenails upon inspection. So this, which would be indicative of hypoxia, which is associated with COPD, and or emphysema, which is a process of COPD. So the chest and the lungs look to be normal. The findings look to be good. So far everything has turned out exactly like we want it to be. Now we're going to inspect the heart. We're going to do a physical assessment of the heart. First I'm going to listen to his heart and him sitting up, and then we'll do it supine. And we're going to be looking for the PMI, which is the proximal maximal impulse. That gives you the point, the apex, where you can hear the heart at the lowest point, and it's usually at the second intercostal space. So we will start assessing for that. You don't have to breathe for this. Well, you need to breathe, but I can hear the heart. It's stronger right here, so it seems like we are over the main area of the heart. Okay, so that is gone. We're going to move up, and I can assess the heart sound right there. It is audible. So it looks like right in this area would be the PMI or the apex. And it is a good heartbeat. The duration is normal. You can hear the S1, the S2, and everything. It sounds like that it is in good condition. Not hearing any murmur, not having hearing any issues that would cause concern. No skip beats that would be indicative of an arrhythmia that would require further testing by possibly an EKG. All right, now if you want to lay supine, we're just going to listen again. Okay, picking up the heart rate again right there. Still picking up the heart rate. I just heard a bowel sound, so I'm going to assume I'm a little lower. So I'm not picking up the heart sound, so we're going to move up. And there's the heart rate. That seems to be the apex right there, which is a normal finding. It does seem to be in the second intercostal space as normal with that. Now we're going to look at the veins and the arteries. First we're going to look at the jugular vein pulsation, and it is observable. The jugular vein is distended, but it is does not seem to be overly distended. You can see the pulsations of it. We're going to start looking at the veins. The veins look to be in good shape. There's no varicosities on the upper extremities. Excuse me. The same on this arm. I'm going to go ahead and assess for a radial pulse, which is easily palpable. I'm going to get a brachial pulse. That is accessible as well. Looking at the lower extremities, everything looks to be in good shape. The veins are not pronounced. They don't seem to be distended. It looks to be normal venous return. We're going to assess in the post-tibial pulse, and both of these are easily palpable. So he is getting good perfusion to the lower extremities. There are no varicosities here as well. We're going to check a Holman sign. A Holman sign just checks for claudication in the calf, which is indicative of deep vein thrombosis. So if there's a DVT in an extremity, the Holman sign, positive Holman sign will show that, which will require further testing, possibly an ultrasound, some thrombolytic treatment, and so we're going to assess that. Tell me, bend your knee just a little bit, Don, and I will hold it. Any pain in the calf?
No.
No pain in this calf? Bend that knee. Any pain?
No.
No pain in that calf? Okay, you can sit up, Don. So there doesn't seem to be any positive Holman sign there. There's no edema to the lower extremities, which would show could possibly be caused by CHF if the lower extremities are pooling fluid, and so there's none there. Doesn't seem to be any edema. We're going to listen for brutes. We're going to listen for a carotid brute and a temporal brute. Just going to assess here. Now I'm picking up a pulse, but I am not hearing any brute. I'm going to do temporal. I'm getting a pulse with no brute was heard on examination. Now we're going to the musculoskeletal system. Don, if you want to stand up right here. And I'll get out of your way because I'm going to let you go into, what I'm going to do is let him walk and just observe his normal gait. If you want to walk to me, and you can walk back. So the gait is normal. His posture is proper. Like as we said earlier, no kyphosis, no scoliosis, no lordosis. He's standing normally. He's in alignment. There is good symmetry there. As we have said, there seems to be no edema anywhere. No tenderness, no crepitus. He does not. There's no heat. He seems cool to touch. Not too cool, but he is. Skin is dry and intact, but it is cool to the touch, so we don't have to worry about any temperature. If you want to sit right here, we're going to assess for TMJ and just see if what we have here. Open your mouth, close it, stick your chin out like an underbite. Now bring it back. Okay, there's no popping. You feel any popping? You got some popping. So he does. Now I feel it. Now he does have slight TMJ, and you knew that. Mm-hmm. So that is that was accessible. You could feel that when we assessed him. You could palpate actually the clicking, the popping in his jaw. So TMJ is there, and he may require treatment for that if he so chooses. So the cervix, the cervical, not the cervix, he does not have that, but the cervical spine is something that we want to assess. It is aligned. This is the junction of the C1 and the T7. It is in alignment. And the neck is symmetrical from his torso, or not symmetrical, but is aligned with his torso. Can you look up? Move your neck around. Did not hear any popping. He may have felt some, but there was no popping visible, no crepitus. So seems like that the cervical area is intact upon rotation. Push your head against my hand. Okay, do it with this one. Okay, the muscle strength is symmetrical. No pain when you were pushing either way. So it does not seem to be from side to side. The lateral movement does not seem to have any pain or issues with the cervical spine. If you can push, okay, push back. Okay, there's proper strength from front to back. So no pain when you push front or back. So the cervical spine does seem to be in place. Going to look at the thoracic spine. As we said earlier, when we were inspecting the chest and the lungs, everything did seem to be symmetrical. The muscle tone is the same definition. When you put your palms, there seems to be, on either side of the thoracic spine, there does seem to be symmetry there. One shoulder is not pronounced above the other, and the muscle alignment is all there. We had him standing earlier and noticed the posture with that, and everything looked in alignment. When we had him bend over for the alignment, it did look proper there. So the thoracic spine looks to be in good order. Now we're going to move to the shoulder. We're going to assess first the sternoclavicular joint, which is right here, and they are both, you can palpate the clavicles and follow those down, and they do seem to be symmetrical. They are both under the, on either side of the trachea, and they are equal. You can follow those out to the coronoclavicular joint, and every one of those, both of those seem to be symmetrical, seem to be the same distance from the torso. No tenderness, no pain, any of that. So everything looks good with that. Now we're going to go around to the back, assess the scapula, and they are, you can palpate those and feel. Those seem to be no edema over those. Those seem to be good. Going to look at the humerus now. Not having any pain. No pain in your bicep or tricep area. Okay, everything, the humerus seems to be good shape, good muscle tone on either side. So there does not seem to be an issue there. The biceps groove is normal. Can you extend both arms? Flex them behind your back. Okay, can you go out, up, and down, all the way down. Rotate your shoulder in, out, with both. So the range of motion's there, not having any problems moving your arm. So the range of motion is there. He has full range of motion in both of his shoulders. So the shoulders all look to be structurally intact with no issues. Now we will go to the elbow. We'll go to the olecranon process. Palpating that, you can also palpate the radius and the ulna, and you can actually follow those up until the olecranon. No pain with either arm. The forearm seems to be in good shape, good muscle tone there. No pain seems to exist, and as we said earlier, the venous return looks to be intact. No lesions of significance that would cause cause for concern. All right, extend your arms out. Bring them back. So the elbows will flex and extend. When he was standing, as we observed upon inspection, the elbow, the angle does seem to be about 10 degrees to 15 degrees, which is proper for the elbow. Does not seem to be any cubitus varus or cubitus valgus, which would mean that the forearm is deviated either in or out, which is an abnormality of the elbow. Put both hands out. Turn them over. Now, push up. All right. Turn over. Push down. Now, it seems to be, the muscle strength seems to be proper in both. It's good muscle strength. It is symmetrical. Not one arm is showing better muscle strength than the other. So the elbows do inspect well. We're going to look at the wrist and the hand. Upon first glance, we do have 10 digits, which is a good thing. The wrist does seem to be intact. I don't see any ganglion cyst, any tingling, numbness of your fingers. That would be indicative of carpal tunnel syndrome, which he is not having. As we said earlier, there's no clubbing of the fingers. Capillary refill is less than 3 seconds. As you inspect the palm, you do see the creases. There's good creases here. You can see the veins of the hands on the dorsal and the palmar aspects of them, and they seem to have good venous return, which is accessible with the capillary refill. Squeeze my hand. Both hands have good muscle strength, and it is symmetrical, equal. Both hands are equal.
Excuse me.
Excuse him. And everything is aligned just like you would want to see it. Touch. What I'm going to do now is just assess by letting him touch each finger to his thumb and then back. And we're not assessing for DUI. We are assessing to make sure that everything is intact with the wrist and the hands, and they are. So the wrist and the hands seem to be good. Now I'm going to get him to stand because we are going to the hips. We're going to inspect the hips, the symmetry. And we had already assessed these when we're doing the iliac lymphatic system, the lymph nodes at the iliac. Where we were going, the hips seem to be symmetrical. They are not quite as round as above the hips, but everything does seem to be in good working order with the hips. No pain, not having any pain at your hips. Can you stand on one foot?
Maybe.
Now stand on the other foot. Okay. So there is strength in both hips. That is the stability and the strength are the same. Now, I'm going to get you to leg up and back and out. And for time reasons, we won't get him to the other side, but we can assume that it would be the same for that, not having any problems. I'm going to get you to lay on your back again. He's getting up and down a lot with this.
Working out of old man.
Can you bring your knee up close to your chest with no pain? Having a little bit of pain, just normal. Having at the iliac crest, maybe having just a little pain, which is normal. It's a stretching exercise more than anything that you see. So it does stretches those muscles like they haven't been, and you can pull the other one about the same level of pain that you were having earlier. So there's no significance of one side being more pain than the other. So that seems to let us know that everything is intact there. Now you can sit up down. We're going to look at the knee, the patella. Everything seems to be in good shape there. Not having any pain around the meniscal areas. The patella is aligned. It is intact. And you can see as it goes, connects to the femur.
Have a little pain on that side.
Having pain here.
A little pain on it, not when you mash though.
Just normal.
Well,
normal
it's
pain.
when I hyperextended.
You feel it when you can feel the pain there. Does it? Your activities of daily living, is it?
No, it doesn't affect it.
Doesn't affect that. Okay. And as you can see, he can extend the leg out and then bring it back to him. He can do the same with this. There doesn't seem to be with his normal standing. Doesn't seem to be any abnormalities, which you'd see the genu valgum and genu varus, which is basically not kneed or bow-legged. And he doesn't seem to be either one of those, so the knees are aligned. They are symmetrical. Everything seems to be where it needs to be. The muscle strength, push up, is good. And it is equal on both. So everything looks to be good. We assessed the popliteal space earlier when we did the popliteal nodes, so everything looks good there. The feet, when we inspected those, when we were doing the pulse, seems to be in good shape. He does have 10 digits. He has 10 toes. His feet seem to be aligned, seem to be in line from the patella down through the foot, which would be going down through the femur and through the femur to the tibia and the fibula. Everything seems to be in line. Doesn't seem to be any bunions. Doesn't seem to be any lesions or anything that would cause you concern. Can you raise your foot? Push it down. Go out. Can you turn your foot in like you were going to look at the bottom of your foot? No pain associated with that. And you can go out like you were going to look at the bottom of your shoe.
Yeah, it would help.
Not having any pain associated with that. Raise your foot. Good strength there, and it is equal strength as well. That is our musculoskeletal assessment. The only thing we have left to do is the cranial nerves, the neurological exam, which we're going to do now, and we will do the deep tendon reflexes. And so we're going to get started. I'm going to go ahead and get my hammer, deep reflex hammer. The first thing you want to do is, when assessing neuro, the first step is, of course, with your inspection. You want to make sure that someone is cognitive. They are oriented to time and place. You know what the day is?
Thursday, the 17th of July.
Where are you?
Dr. Harding's office.
That's right. And who's President of the United States?
Barack Obama.
So he is cognitive, he is oriented. I won't ask him what he thinks of the President to assess his judgment, but he seems to have proper judgment. And so everything, as far as a inspectable neuro assessment, he does seem to have all of his neurological system intact. But we're going to check for the cranial nerves. The first thing we want to assess is smell. So your smell is proper. I'm going to assume I don't have a cotton ball. I was going to get alcohol. We do have Purell. Can you smell?
Yes.
Smell the difference. So his smell, which does assess cranial nerve 1, his smell is intact with both nares. We did the eyes earlier when we did the extraocular muscles, the eye movement, the 6 cardinal fields of gaze did assess for the cranial nerve 2, and it also did assess 6 and 7. We're going to look at the symmetry of the face. Raise your eyebrows. Eyebrows raised. Squeeze your eyebrows down. Squint your eyebrows. So the eyebrows do work, which we are looking at the symmetry of face, which is cranial nerve 7. Squeeze your eyes shut. Wrinkle your forehead. Raise your eyebrows and wrinkle your forehead. Now, smile, frown. Not having any trouble doing any of that. And it is symmetrical. One thing you want to look at is make sure you're not having any drooping to one side with these cranial nerves. And so, because you have, you may have Bell's palsy and you may have stroke. So the cranial nerves, you're not having any trouble swallowing?
Nope.
Shrugging your shoulders? Stick your tongue out? Okay, everything looks good. Pat your knees with your hands. This is just testing coordination. Touch my finger. Touch your nose. Finger. Nose. Okay, let's assess this. And his foot did move. And that foot did move. So that did do the reflex for his knee. We're going to do the bicep or the tricep area. Everything seems to be intact. I'm going to put my thumb there. I'm going to do the bicep. And that does make the hand or the arm pronate some. Okay, and so we did assess the brachioradial and the triceps and the bicep and the patellar. Now we're going to do the abdominal. Lay supine. We only have 2 more reflexes to do, and the neuro assessment will be done. Feel that?
Yes.
Feel a little
Yes.
tickling? Okay. So the abdominal is in area. Can you lay on your stomach? I'm going to hold his foot and strike his Achilles. And you can feel his foot want to move. So everything does seem to be, yeah, you can feel that definitely. Okay. Well, that is the physical assessment for Nursing 305. My name is Jeff Pipkin, and hope I get a good grade. Thank you.